We are going to start to discuss the different points of the guidelines. So the question could be what I remember from the guidelines. And unpublished guidelines today are going to be published soon, both in Intensive Care Medicine and European Respiratory Journal, no, European Journal of Anesthesia. So thank you, Samir, for this precision. What I remember from the guidelines, we have some points to discuss. First, what goal of therapy are be expected when using this type of support? In other words, it means how to fight against the changes, physiological changes you described, Samir. So is the first point clear for everybody? Or we should discuss this point?
This point is a major one to understand what the choice between, as you said, only oxygen, the same thing, standard oxygen or high flow oxygen, because only oxygen, one pressure level, that's called CPAP or VSPIP, and two pressure, often called NPPV for non-invasive positive pressure ventilator, sometimes called BiPAP. This is very important to have the different terms. So if it's only hypoxemia, probably we should consider, or it will be considered only a strategy to give oxygenation, like high flow oxygen or CPAP alone. However, if you have hypoalveolar ventilation, that means hypercapnia, it makes no sense to use oxygen alone, or it makes no sense to use CPAP alone if you have moderate to severe hypercapnia. This is very important to understand this. And it's very important to understand the mechanism that to help to change the setting. If you have hypercapnia, you should probably increase pressure support ventilation, that it's act as accessory muscles. And then if you have only hypoxemia without hypercapnia, probably oxygenation alone could be enough for the majority of the patient. That is your question,
sure.
Jean-Michel, when you said why we not use more, probably a single one, which is CPAP. This is very important to understand. That's a major issue.
If I go further to your meaning, it means that it makes no sense to use two-level positive pressure for a patient with only hypoxemic.
Absolutely.
So just CPAP or just PEEP, whatever you want, could be enough.
Except if you are a believer of the preventive way. Like if you're running, probably if you run a lot, and if you take the car, probably you prevent the respiratory muscle fatigue. Could be another approach. That's why it's different. Not that the curative and the prevention should be taken into account in these two approaches.
Absolutely.
But you're absolutely right when you said it makes no sense if you want to treat only hypoxemia to use ventilation. But this is not contradictory if you take into account the prevention.
So oxygen and one level of pressure. If I go back to my slide, please, to move on to the second question. Just before, this is not in the guideline, but I think this is really important for us. I don't know if you know this recommendation published in the British Medical Journal 2 years ago, because it's probably an issue in perioperative medicine, is the target of oxygenation. And in my hospital, in my ICU, my post-anesthesia care unit, the level of oxygenation of our patient is too high. And I spend all my time to say, decrease the target. And I think it's well summarized in this table. Oh, too quick. Probably we should not give oxygen if the SpO2 is 96. But what is most important, I think, in this picture is that we should not start oxygen. We should not use FiO2 higher than 21 if the SpO2 is at the level of 93. Is it correct for you, this statement? If your patient after anesthesia have a SpO2 of 94%, who will not use oxygen? Just pressure if you need pressure, but not oxygen. Are you agree with that?
For me, it depends on the patient and of his risk of hypoxemia and of apnea, especially during the post-operative period, and the dose of opioids, for example, used. So maybe in this particular setting, in case of or analgesia with opioids, maybe some oxygen to prevent desaturation during apnea period could be useful.
But do you think that giving oxygen to a patient who is not hypoxemic makes sense? I'm not sure. Maybe we can give pressure to the patient, but we can give pressure with low FiO2, no? It's not common care, but...
Jean-Michel,
Yeah.
I am totally agree with you.
Oh,
And
thank
I
you,
have
Samuel.
exactly the same problem like you every day in our unit. Then, I don't know how we can explain. I dropped today. Then, probably, I try to explain what you said by making a comparison that if you have an objective for arterial pressure using, I don't know, vasopressive like noradrenaline, you don't give noradrenaline if you don't need noradrenaline. If you have hyperglycemia, you give insulin. But if you don't have hyperglycemia, you don't give insulin. Then I said what you said. If you are not hypoxemic, you said, I don't know, 94, 95%, you don't need oxygen. However, probably you have, I don't know, some suggest that you can have side effects in hyperoxia. That probably every day, each day in our unit, we have at least more than 2/3 of, more than 70% of patients want 100%. That probably the major issue is try to learn that the oxygen should not be given just a flow, but should give according
A target.
a target of
Sure.
oxygen. And this is very difficult. It's easy to understand for glycemia, for arterial pressure, for pain, for fever, then all your symptomatic treatment. However, oxygen, we don't know. With Professor Gerald Schenk in our unit, we try to have the alarm, the upper airway alarm at 98, 97, 99. Probably
Just 99, it's enough,
just
I think.
99 is the first step.
Yeah,
because
sure.
you don't know what happened 100, you don't know what is it. It could be 100 millimeter of mercury, but 120, and then this is a little joke, but it's really, I totally agree with
Do
Jean-Michel.
you have the same issue in Italia?
Yes.
Thank you.
I totally agree for this. It's interesting to see that 1 or 2 years ago, the World Health Organization produced a statement on this, stating that in perioperative time, anesthesia group should administer 70 or higher % of FiO2 to reduce the wound infection. So the outcome that the World Health Organization set as the primary goal was the infection of the wound. It is important to note that this statement should be followed up after the surgery. It's incredible to know that our community, critical care and anesthesiologists, rarely believe on this. So we have an important statement for the most important organization worldwide that say, for the whole picture of patients, you should administer oxygen by this, and you should not take into account the oxygenation with a saturimeter or the PiO2, because you should reduce the infection. And the real world community that say, this makes no sense.
But it depends also on the setting. If we are in the ICU setting, I totally agree with you. But we have also patients not closely monitored. And in this case, maybe to prevent accidents during desaturation, maybe in the ward, not in ICU, I was meaning.
No, you absolutely. We said all the same thing.
Sure.
Jean-Michel spoke about patient with monitoring, especially with pulse oxygen saturation, and he said just probably it makes no sense to give a patient with a 95% ambient air to deliver oxygen. This is the issue of Jean-Michel, and I said 100 is probably no good. This is, all of us agree. It's another case if you are in the ward, a patient that you don't know, but probably it's better. Probably if you should choose, I prefer one patient with 100% of oxygen than 90% with no. This is we all.
But she's the youngest and she personalizes the choice. So
You're absolutely
this
right.
is perfectly. Could I have my slide back, please? So move after this one. So what should we discuss now after this one? Which patient population may benefit from the use of this type of support? This is probably a really important issue to choose patient or to take care of them. Some discussion of this point, or the data are clear?
Absolutely not. The panel did not recommend anything about this. The only statement was to describe, based on expert opinion, that it makes sense to base the monitoring of frequent clinical assessment, blood gases, also saturimeter and electrocardiography in continuum, just to keep the patient up and to monitor the development of hypoxemia or further deterioration. And the evidence came from the study that I mentioned, but not as primary goal. So the panel looked for this, not from study that specifically addressed this point, but has secondary issue of the trial. So the evidence is absolutely not clear for this.
Okay. So what could be the solution for a patient? It's a step-down unit to monitor high-risk patient or patient have high-risk surgery. What are you doing with this patient in Montpellier, for example? Where do you put the patient after surgery? One of you.
So we are working in the same unit. So in Montpellier, this patient at high risk are going to intensive care unit or intermediate unit, but not in the ward, to be closely monitored. If you want to complete.
Yes, as we discussed in this previous session with Eric Deflandre, it was a session focusing on obese patient, meaning at risk, as you said, Jean-Michel. And the recommendation is probably the better is try to screen very early the patient who could be at high risk. And this patient probably should be addressed to the at least post-anesthesia care during at least 1 or 2 days, and for the more severe at high risk to be at ICU, maybe for 1, 2, or 3 days, because as we know, it's probably during the 2 first days after surgery, the major risk. This is only for the patient at high risk. So the question is how we could consider high-risk patient. Probably in a clinical practice, we know that the patient with a lot of comorbidities, with a high BMI, with a history of cardiac failure, with respiratory failure, that probably is high. Then we have some scores, define the risk patients. The Azure score on the most recent one is the score coming from our friend J.M CONSTANTIN from Barcelona. It's, as you know, the IRIS-CAT score, and the IRIS score includes different physiological variables, different paraclinic, different biological variables, including that more you have a high score, more you have risk to develop. And then probably we said that 24 is patient at high risk and should be considered to be really close beam monitoring.
I think this message is important, is to use score scale to stratify the patient and to help physician to put the good patient in the good place. And sometimes it's difficult to use all these different scores. For our friend of the Francophonia, from France, from Africa, for whatever the world, we have in the e-sfar application, now you have the different score that we can use in the consultation of anesthesia consultation, and probably to put the patient in the good way after the surgical procedure. Are you agree with the score? Do you use score in Italia to split the patient?
But I think that the IRIS-CAT score now is widely used worldwide because as a validation, an internal validation, an external validation, so it's validated on a very large cohort of patients, and it is a good score to cut off patients. And obviously, the pathway of care depends on the logistic issue of each center. But another point, in my opinion, is not only about monitoring, which kind of monitoring, is about availability of the skill. I mean, if you say in the world you should monitor in this, and you don't have the skill, the available skill for interpretation of blood gases of clinical picture, or the knowledge about ventilation of non-invasive support, this is a problem. So it's not about monitoring, it's the viability of the skill.
Absolutely.
And just to complete what the concern of Jean-Michel, in my point of view, in the real life, nobody uses the score in the real life. The score is dedicated for publication, for better screen and for better define the type of patient who will be included in the study, which it's helpful to interpret the study and the results. However, in the real life, we have our feeling. Our feeling is, oh, this is probably a patient at high risk. This, you cannot write this in the original publication, so you need for the publication or for the inclusion a score. But the score is, in a simple way, the surrogate of what is the feeling of the physician. Are you agree with this?
Yeah, but the feeling is not so good to my point of view, and I believe that we need score
The skill is.
to promote the
objective.
good care, the good skills, and to take care about
But
this
in
patient.
the real life, it's very hard for us to have at the consultation. You can, it's very. Audrey maybe he can say his experience because every day he have some patient in consultation. But in the real life, in my point of view, it's very difficult for all patients to have the score. However, in the ordinateur or the computer.
Yes, maybe we use the components of the score without calculating the score or a particular threshold, and then using the components, but more intuitively, as he said, we decide where to put the patient after the surgery, and it also depends on the way of the surgery occurs.
Sure.
If there is any complication during the surgery, we will also more closely monitor the patient.
Sure, you're right. But if I make a short comparison with hemodynamic monitoring, we all know we have paper and paper showing that if you just look to the blood pressure, heart rate, and urine output, you increase dramatically complication versus cardiac output monitoring. And you still have some anesthesiologists who monitor hemodynamic with blood pressure and heart rate. We should not do that. And I believe that it's the same thing to split patient at risk or not at risk of high risk postoperative complication respiratory. So we need to use score, to my point of view, I think. If I could have my slide back, thank you. Next point, I think is do not delay, and we all say that, do not delay intubation of our patient because it's dramatic issue for a patient to delay the intubation. And the question could be, can we predict and or avoid NIV failure? Whatever CPAP or B-level pressure or high flow nasal oxygen. I think this is a major issue. Do you have a comment on this point? One of you? I will have some time to discuss this point. Well,
Obviously,
this is an important point, I believe.
absolutely, the failure of any of this intervention is very dangerous. Obviously, to monitor the failure, you should follow the patients in a setting that lets you monitor correctly what you want to monitor first, and then there is a physician that should understand what really is treatment failure. Again, we don't have a clear definition of treatment failure, and it depends on the feeling, as we discussed before. I can think that this patient is not responding to CPAP. I can feel that this patient is not responding to an NIPPV or high flow. So even for this, the feeling of the physician should be taken into account, but it depends on the physician, of course.
And the skill of the physician. Maybe we can be helped with some score one more time. If I have my slide, please. There are two scores have been published recently. One with high flow for French and America is a works score, really easy. SpO2 divided by the FiO2, it means the response in terms of oxygenation divided by the respiratory rate. And probably, maybe Sam, you could comment, I believe that respiratory rate is a really good surrogate of the efficiency of the support we give to the patient. If the patient do not decrease his respiratory rate after 1, 2, or 3 hours, maybe we need to stop. What do you think about that, Sam?
Totally agree with you.
And, my slide, please. We have the same score, quite the same, published in intensive care medicine, is the HICOR score. But one more time, the most heavy point of the HICOR score is respiratory rate. And it's easy to monitor. It's so evident when you are just looking to the patient. And I think we have to take into account that if they do not decrease the respiratory rate, maybe we need to intubate our patient. One more point on this, one discussion on this point.
As you said, Jean-Michel, you have two major issues. One, you have the values of the score, and you have the evolution. That means if you have evolution with increase that you increase the risk. If you don't have an improvement, probably, as you said, you will stop to take non-invasive ventilator support and probably intubate the patient. This is a very major issue.
I think the concern in that if we just look to oxygenation, we miss some patient and we delay intubation. Because if you increase FiO2, you increase oxygenation at least for 1, 2, or 3 hours. And probably focusing on respiratory rate could make sense for our patient. So one last point, where should treatment with this support be initiated? Probably difficult to have any recommendation on this point.
In fact, there is no recommendation on this point. There is only one study study one of the treatment of the review, the CPAP, outside an ICU environment and especially in the cardiac surgery ward, but only one study with almost 70 patients. So it's clearly not enough to know if outside the ICU and outside some sort of monitoring packaging it's okay to apply this kind of ventilatory support. So in my opinion, this should take into account on base by base, so center by center and physician by physician. I know that this is not a good point and this not can be written down in a paper, but the skill of the physician that should interpret the clinical picture is the only way to avoid the deterioration of the patients when receiving non-invasive respiratory support.
And maybe we should use only devices with team who have been trained with this device. I think maybe it's a little bit trivial, but if your nurses in your post-anesthesia care are not familiar with NIV, maybe we should not use NIV, use iFlow or something like that, or just CPAP. Does it make sense for you to look at the training of the teams?
Yes, we totally agree.
So, thanks to all to be here. We're going to conclude on this session. I think this recommendation will be really helpful for physicians worldwide on the care of perioperative complication and after surgery. Samir, one word to conclude?
Yes, 2 things. First of all, please, if you have only one message each time when you have post-acute respiratory failure, please, before do anything, eliminate a surgical complication. Because if you treat with a symptomatic treatment, don't forget the oxygenation and invasive is only symptomatic, you delay and you have your bad outcome. This is the first thing. And the last one, I want, Jean-Michel, thanks first of all, Marc Léon, who led this consensus, and all the group, you, Andrea, Jean-Michel, and our friend, because it's really nice guidelines, and these guidelines will be published in both, coming from the 2 societies, the ESICM and the ESA, then in one, in, as you said, in the European Journal of Anesthesia, and one in Intensive Care Medicine Journal very soon. Thank you, Jean-Michel.
It was a hard work for everybody. It's a long work, but I think it's really good guideline, really important guidelines. So follow them and take care of your patient. Thanks to everybody. Have a good day.
Thank you very much for everybody.
You.
Thank you.